All right, excellent. Welcome everyone to Citywide Medical Grand Rounds today, December 5th. St. Joe's is the host site. Next slide. So I'm Dr. Madeline Verhofsek. I'm the Chief of Medicine here at St. Joseph Healthcare Hamilton, and it's my pleasure to provide our land acknowledgements to start today. We acknowledge that St. Joseph Healthcare Hamilton sits on the traditional territories of the Mississaugas and the Haudenosaunee nations and is within the lands protected by the Dish with One Spoon Wampum Agreement. This is a treaty between the Anishinabe, Mississaugas, and Haudenosaunee that bound them to share the territory and to protect the land. Subsequent Indigenous nations and peoples, Europeans, and all newcomers have been invited into this treaty in the spirit of peace, friendship, and respect. So up to our next slide. So I'm delighted today to welcome Dr. Carson Lo. He's our newest staff infectious disease doctor, having joined around this time last year. He is going to present on the topic of Pneumocystis jirovecii pneumonia in the non-HIV population. And as my co-host today, we're pleased to have Dr. Zain Chagla joining. And I'll hand it over to Dr. Chagla to provide more information about Dr. Lo.
Hi, good afternoon, everyone. So I'm Zain Chagla. I'm an ID physician at St. Joe's and head of service, and very happy to introduce Dr. Lo. Dr. Lo completed his internal medicine residency at Queen's University, his infectious disease residency at McMaster, and pursued a fellowship in transplant infectious diseases at the University of Toronto and University Health Network. He is currently an assistant professor and staff physician at St. Joseph's Healthcare with a focus on the treatment and prevention of infections in solid organ transplant recipients. He also recently completed his master's in medical education at the University of Dundee with an interest in contributing to ID teaching material with a focus on the immunocompromised. And with that kind of introduces this talk of a really interesting subject, which I think is changing quite a bit. And so I'll turn it over to Carson to lead us off.
Thanks, Zain. My name is Carson. I'm going to be talking today about the Pneumocystis jirovecii pneumonia, PJP, in the non-HIV population. If there's any issues with the slides or anything, just please let me know. I have no conflicts of interest. For today, we're going to be going over several questions that I came up with along the time that I was searching about more for Pneumocystis jirovecii, and that would be of interest for the group. The interesting thing that I would point out, though, as a theme across all the questions that I've had here on this slide, is that as we go through while we think there may be some straightforward answers towards maybe recommendations or therapy or management or diagnostics, what I did find is that along the way, many of these questions remain difficult to answer or sometimes left open to discussion still. So starting off with the first question, what is Pneumocystis jirovecii? Is it a bacteria, fungus, or parasite? And I would say the best way to describe it is it's still kind of in a bit of a debate at this time. Could be a bit of both. Starting with a bit of history, just to kind of contextualize where Pneumocystis jirovecii came from. So as early as in the 1900s, it was first discovered as a parasite by Dr. Chagas and Dr. Carini. And at that time, the pathogen was first only isolated and named as parasite, but it took about 50 years before it then later got described as a human disease in malnourished children. And later on, only about 20 to 30 years later, was it further recognized in the higher incidence, specifically in the HIV infected individuals, where more than 200,000 cases of PJP was reported around the time of upwards to 1979, where a quarter of cases of community-acquired pneumonias were in fact due to this pathogen. At that time, it was named as Pneumocystis carinii pneumonia and was recognized as an AIDS-defining illness. It took about another 10 or 20 years after. Then it got renamed after the parasitologist Dr. Jirovecii in recognition for his work for host specificity of this organism. But consequently, at the same time, while it was being described as a parasite, it was also at the same time being recognized in the form of a fungi. There are certain properties of this pathogen, specifically on the cell surface, where they would contain beta-1,3 glucan, which is one of the elements that are one of the components that are seen in the structures of other fungal organisms. Yet at the same time, it is lacking in terms of ergosterol, another important component on cell walls of fungal organisms, making it a bit hard to categorize where it best fits. That said, under the taxonomic kingdom of fungi, it was recognized, at least by genome sequencing, for Pneumocystis jirovecii. Despite so, it is still being described many times with stages of its different life cycles, such as trophozoid and sporozoites, namely still using names that are still in the categories of protozoa or parasites. So it remains actually quite confusing to the state where it really belongs. The next question I had was, where is jirovecii, Pneumocystis jirovecii found, and where it could be from? It's important to distinguish this from the other pathogens that are isolated in variants of other animals, as Pneumocystis jirovecii is primarily a human disease and infection, but it has not to this date, because of its inability to be isolated in the testing environment properly. There has been no ability to tell us whether or not there was any environmental reservoirs available. There are some studies, though, however, that seem to suggest that perhaps since childhood there may be exposures to this pathogen, with specifically those with immunodeficiencies that may present with a symptomatic disease. That said, de novo infections and nosocomial transmissions are still being reported, and more specifically in the immunocompromised host. So it has been reported before in transplant patients and transplant wards in the past. So who is at risk for developing PJP? Well, classically, it had been described in the group that had the largest impact during the time in the 1970s, 1980s in the HIV population, where those with low CD4 counts, less than 200 or less than 20% of total circulating lymphocytes, have been described as those at risk, and had also been the reason and the drive towards developing guidelines for primary prophylaxis for this specific population. But then the question is, who else may benefit from primary prophylaxis besides in the HIV population? So some considerations include with those described in corticosteroid use. This would perhaps be the largest group that have been recognized in a number of studies that have been published in the past. A lot of us are familiar with perhaps the dosage of how much prednisone is warranting one to consider prophylaxis, specifically more than 20 milligrams per day of prednisone or equivalent dosing for over a month. However, there's actually no high-quality evidence to suggest specifically what and when to guide prophylaxis specifically for those receiving prednisones in different dosages or different durations. What I do want to point out, though, is perhaps it may be a consideration of the cumulative dose that one would have from the steroids and the duration that might govern how we would recommend the prophylaxis for those who may benefit the most. The other things also is that not all patients are typically receiving just primarily corticosteroids as the main means of therapy. There are other therapies that are potentially immunosuppressing, resulting in a net state of immunosuppression that the patients may have that would impact the likelihood of that they may benefit from prophylaxis. Other things to consider as well include lymphopenia and prolonged neutropenia. The other drugs that I'm alluding to, there's a really long list that one would find if they tried to search through primary literature. A lot of it is primarily in smaller observational studies, sometimes perhaps in clinical trials as well. The list I have here is just some examples of drugs that have been reported with PJP. It's certainly a non-exhaustive list, but to give out some examples, for instance, cytarabine used in hematologic malignancies and AML, for example, as induction, or fludarabine used in conditioning therapies before stem cell transplants, as well as CLL treatments like ibrutinib, are examples of which where patients may benefit potentially from consideration of PJP primary prophylaxis. But what I find is it's also understanding the myelosuppressive nature of these drugs, its intensities and duration of neutropenia, but as well also the underlying disease of these patients. As for example, CLL may have some combination of both the therapy and the dysfunctional lymphopenia that might impact the risk of developing PJP. So in terms of populations that are at risk of developing PJP, the ones that I would consider and the ones that I've specifically highlighted or in bold are those of transplantation, including SOT, solid organ stem cell transplants, those undergoing rejections, as well as other patients with hematologic malignancies, are those that actually have established guidelines and established indications for primary prophylaxis. The other groups that are listed here, such as in the rheumatologic diseases, inflammatory conditions, where they also use high doses of steroids and other immunosuppressive agents, may also be within considerations as well, but guidelines have not necessarily had very strong indications to say that they have to be on prophylaxis, but has been suggested at least. So the take home for who is at risk for developing PJP, I would say specifically for primary prophylaxis, it's some of these different considerations, including net state of immunosuppression, their underlying diseases, and the therapies they received. However, at the same time, we do need additional studies that would look at a greater scope in terms of which patients actually in fact develop PJP in these select populations and therapies in combination, as well, which we're going to move on to next, about the diagnostic therapy, diagnostics that we have, such as PCR, that may actually in fact increase our ability and the sensitivity of identifying PJP, and may change our way of defining those who are at risk moving forward. So this slide is just there in case if there's opportunity to share these slides for presentation later, just options of prophylaxis that are available for considerations in those who would indicate for primary or secondary prophylaxis. So moving on to diagnostics, in terms of specific imaging findings that might be suggestive of PJP, unfortunately, there's actually not really any specific radiographic patterns that are pathognomonic. A lot of times it actually depends on when and how the patient was, at what time they were imaged. Because, for example, if they're early PJP, they may show some fine perihilar infiltrates at first, which may then later on spread into the periphery, spread in an alveolar butterfly pattern, but typically remain peripheral sparing. But the disease may sometimes progress and start presenting with atypical findings as well, including nodular changes, lymphadenopathy, or even sometimes consolidative changes. All in all, to say is there's not a single imaging alone that would be indicative of PJP as a single test. Likewise, for laboratory tests, there are not a specific labs that are capable of helping with a presumptive diagnosis of PJP. What we do have available is the test for LDH in blood. However, these are often also elevated or seen in other malignancies or hematologic malignancies as well, so maybe may impact the actual reliability of the test. We do have in other centers, not specifically in Ontario and perhaps not readily available in Canada, a microbiologic or serologic test called beta-D-glucan that has a relatively high sensitivity and a good negative predictive value, but it's quite non-specific, as if it's positive, it actually could be indicative of multiple different other fungal pathogens of infection as well. So then what kind of tests could we have that are available for testing for PJP? A lot of times we rely heavily on microscopic methods. There are some issues with the microscopic methods, however. The goal of it is to help diagnose or confirm the PJP presence versus colonization. Other times we would hope that the microscopy or the microbiologic test would be able to help us quantify or provide therapeutic monitoring if there is in fact ability to detect how much pathogens are present. What we traditionally had was a method called DFA, which is using immunofluorescence antibody staining against the specimens that are retrieved from patients. These are typically from BAL samples or sputum samples. And after staining, we're able to say the presence of or detection of the pathogen. What it does lack, though, however, is the exact quantitation and amount of pathogen and burden, and it also depends on actually the patient population. If a patient has low fungal burden, then typically the yield might actually result in some false negative tests. So, on the other hand, histopathology is an alternative where we could consider using GMS stains or GMS on BAL samples and induced sputums. However, oftentimes these are labor intensive, and if needed to obtain, sometimes may require biopsies as well, which are rather more invasive and often reserved in cases where induced sputums are not feasible or where microbiologic testing is no longer capable or not possible for the patient, or a negative test. Here's just some examples of some of the histopathologic findings that could be seen. On the left side here is an H&E stain, where there may be sometimes examples of foamy amorphous material or eosinophilic infiltrates that are seen. whereas on the right side is a GMS stain. As an example of some of these small little organisms would be what we call helmet-shaped or cup-shaped rounded Pneumocystis organisms that are appreciated by the staining technique.
So
some of the disadvantages of using both the traditional DFA immunofluorescence test and histopathology is a lot of times it depends, as I said, the quality of the sample and the patient population as well. So, for example, lower respiratory samples or specimens typically have a higher sensitivity than it does with induced sputums and may affect the yield of the test. Specifically in the HIV population, oftentimes PJP is presenting with a higher fungal burden, so the use of DFA remains to be an ideal option. However, the population that were of interest now in the non-HIV population that are increasing with the recognition of PJP in those groups, it may actually end up having a false negative test or less sensitive than perhaps a PCR. A lot of these tests, both the histopathology and also the DFA, are very labor intensive and also requires the skill of the technician to perform. And also the other issue we have is that if the samples are obtained and kept greater than 3 hours, there's a instability or disintegration of the pneumocystis cells and actually may result in a false negative test as well. Another thing that's lacking with both of these tests is the inability to monitor or to test for resistance, specifically in vitro susceptibility by microscopic methods due to the difficulty of isolating Pneumocystis jirovecii in the samples that are obtained. So what are we using now for PJP diagnostics? At this time, we are using something called real-time PCR. What it does is that it is a specific detection of the DNA to Pneumocystis jirovecii, where we will extract from the patient's samples, be it a BAL, induced sputum, or biopsy. And from that sample, we would then amplify it for detection. And with that, we'll be able to detect the presence of or suggestive of presence of PJP. These tests could either be commercially available and purchased from third party, or more so typically developed in-house by our own local laboratories. So there has been a lot of different quoted sensitivities and specificities of these tests. In the past 20 years, about 16 studies have reported the testing of their own developed PJP PCR in bronchoalveolar lavage specimens. Sensitivity was quoted anywhere between 91 to close to 100%, with the specificity being slightly lower at about 9, ranging from 82 to 95. In any way, it is going to depend on the patient population and how, the population at risk that they're serving, that they're testing these samples from, the method of sampling these patients, whether it's coming from BAL versus from induced sputum, that would affect kind of the yield of these tests. So what is available at least at HHS and also at St. Joe's? We also do offer the real-time PCR that's been developed in-house by our microbiologist team and the technicians, and together has been launched in use now since April 2023. And up to this time, about over 12,000 samples have already been tested in over 600 patient samples. Roughly about 63 of them have been detected or positive. The way the test works is it's mainly a semi-quantitative study, or semi-quantitative test, where the sample would be then extracted and amplified over a period of time, where if it reaches a threshold of about 33, if it's anywhere less than 33 cycle thresholds, but is then detected, it would be considered as a positive sample, versus if it never reaches the threshold, it would be considered as a negative sample. The one in the middle here would be what we have as probable colonization, where a sample does get ultimately detected, but it's past the threshold of 33 that we use to cut off for a colonization. In this case, we would name it as not a negative sample here, which is a typo. It's actually meant to interpret as a probable colonization here, and it would be left for the clinician's interpretation whether or not they think this is in fact a patient who's got diagnosed as a PJP or not. So it remains a bit difficult at this time in terms of being able to have a quantitative measure for PJP by PCR, namely because of the methods of sampling are different. Some are taken from BAL samples, others are taken from sputum specimens. So there is some future directions of interest where perhaps if there is a role for quantitative measurements, having an actual fungal load or fungal copies detected, whether or not that might be useful for therapeutic monitoring in the future, but certainly does need to be validated across the different sample methods first. The opportunity of using PCR also opens up the landscape of being able to consider for resistance testing, as well as potentially maybe looking for other less invasive methods of sampling, such as an MP swab, rather than obtaining through an induced sputum or BAL, which is oftentimes more challenging to do in a clinical setting. So moving on to management considerations. Again, we're not talking about specifically the management drugs here, but it's available for others to review if we're going to share the slides. But the question that we have here is the role of adding steroids in the setting of PJP management in the non-HIV population. So that begs the question first of what is or where is the evidence for corticosteroids coming from? A lot of us may have either seen or previously prescribed, when managing PJP pneumonia, a regimen of prednisone in the form of a 5-day, twice daily, followed by a taper to 5 days daily, then daily at a lower dose for the remaining 11 days of the 21-day treatment of PJP. However, interestingly, if we're trying to find where it came from, it was initially through a NEJM publication back in 1990 that was a consensus statement regarding management of HIV positive individuals. And it was based on 5 separate trials that have been published of varying patient pools and patient sizes that they recruited. The largest study is the one here on study B, which is about 251 patients from the California Collaborative Treatment Group that seemed to have formed the basis of which this steroid therapy was justified from. Over here is just the detail of where the consensus statement had in terms of recommending this regimen that we're seeing nowadays and still used to this date. Options using oral steroids or an equivalent of IV therapy if they're not able to take oral. But to look at the actual data of what substantiates and why they chose this steroid regimen is kind of interesting, because if you look at the NEJM study from 1990, where this regimen was first developed, there was no rationale actually provided for why they decided on this kind of 21-day steroid with a taper regimen. It was just that across the different studies that had been published at the time, different studies had tried different varying regimens, and this one happened to be the study that was the largest number of samples with a good outcome that was identified, which is over here, where specifically they're looking at the cumulative risk for mortality as well as cumulative risk for failure of these patients. And what they have found was that the group that received standard no steroid standard treatment, which is marked by yellow now and on the top, is that the patients had a significant reduction in the risk of respiratory failure and mortality following introduction of this 21-day steroid regimen. If we're thinking of more updated data nowadays, there was a systematic review that was done that I didn't include here from 2015 that did show still a relative risk reduction of overall mortality by about 40%, both in the 1 month and the 3-month mortality data, specifically in the HIV population. The number needed to treat was about 9 patients if the patient was never started on antiretrovirals. Whereas if they were on antiretrovirals, then the number needed to treat would be about 23. So still at this time, early steroid use within 72 hours after starting PJP therapy, at least for HIV population, remains to be still indicated. But then what about the patients in the non-HIV population? That, on the other hand, is actually still quite limited in terms of the studies that are available. I tried to present a couple of these as examples of how much has been done so far. A lot of these are just based on reviews of meta-analyses of observational studies, such as this one here, where they looked at 16 different papers of up to 2,500 patients across the 20-year period. Majority of these patients are primarily solid tumor or hematologic malignancy patients. And what they have found was that on the top figure here, if they included all of the patients of all cases of PJP, in non-HIV population, what they found was that there's an association between increased mortality on actually when corticosteroids were used as adjunctive therapy for PJP management. Conversely, though, they did see a trend towards a potential benefit of decreased mortality among patients who are hypoxemic, who have PJP and required steroids use. They then did some further subgroup analyses that looked at specifically patients who have respiratory failure. And again, what they did find was that there's a significant lower mortality in the non-HIV patients with PJP with respiratory failure, having received steroids, demonstrating that there may be some benefits. All to say is that this meta-analysis did seem to suggest that those specifically with respiratory failure may in fact have some better clinical outcomes with less mortality associated if steroids were used. And perhaps in the larger population, if there was any patients included, both non-respiratory and respiratory failure, that maybe there may be more harm done. No matter what, I think more clinical trials and other studies are still needed before we can actually substantiate or make some kind of meaningful recommendations of whether or not steroids could be used based on this data. Here are just some other examples of other patient studies that have been done. In this case, it was in patients without HIV, but use of early corticosteroids within 72 hours. And what they did find in this study of 323 patients, they specifically looked at whether or not there's any improvement in the SOFA score of these patients admitted through the ICU at day 5 in those with steroids versus no steroids. And here what they have found, at least, was that there have been no benefits seen or associated with less improvement in those who received steroids compared to those who did not. They also looked at whether or not at least a single point change in SOFA score had substantiated any changes between the steroids group and the non-steroids group, and they had found no differences between that in this case. A more recent study looking at specifically in the solid organ transplant patients, which is one of the groups that have a strong indication for primary prophylaxis for PJP. What they did find, though, over the course of the study of 5 years across 20 different transplant centers, most of these patients are primarily kidney transplants, having at least received either ATG or basiliximab as induction with standard immunosuppression. What they did see in this group was that for mortality as well as ICU admission, and also for composite outcomes, when adjusted by propensity score, there was not any associated reduced risk between the groups of steroids and also no steroids treatment. And what that at least here seems to suggest is that we didn't at least have seen or observe any significant associations between steroids and the ICU outcomes and death. Still, at this point, we don't have enough data to reevaluate the use of routine steroids. So what that leads us to is at least the two statements that I have here. While we have limited evidence at this moment for the use of steroids in the non-HIV population, perhaps we may consider it on a case-by-case basis, and more specifically in the groups of patients whom there is a severe cases of hypoxemia, whereby maybe there may be some benefit in use of it within 72 hours of initiation of other antibiotics at the same time. Finally, this brings us over to one of the last topics to consider, which is managements and considerations of resistance. So actually, when we think of resistance, it actually typically doesn't often get considered, be it one, we don't actually have much readily available testings for demonstrations of mutations or resistance seen in patients on therapy, and most times than not, patients do improve on full dose of Septra. And the reason being, if we look at the specific gene that's responsible, which is the FAST gene that encodes this protein responsible, DHPS responsible for PJP resistance, is that actually, despite the presence of the mutations seen, at least in study or in vitro, it hasn't demonstrated or been correlated with clinical resistance, at least. Patients seem to still respond when they're given the first-line therapy. So all in all, to say it's still quite uncommon. And the times of which where we might consider switching a patient or changing therapy, perhaps, I would say if a patient's received at least 2 weeks of therapy of adequate dosing for their PJP treatment. If they're not already on Septra, then we would consider using Septra as the first line, given that there has been some demonstrations that use of Septra at full dose has shown ability to overcome potentially resistance and treatment failure. And if the patient's already on Septra with optimal dosing, then we may consider switching over to other alternatives, understanding that the alternative drug options oftentimes are seen as somewhat lesser or inferior to the option of Septra here. At this point, there still isn't any kind of cutoffs or interpretations of how to use the data, even if we did find the resistance. And as such, there's no clear recommendations made for when to consider it as well. What we do look forward to in the future is if with the now ongoing use of PCR for diagnosis of PJP, is whether or not this could be then considerably be added on to the additional platform of the PCR testing, and whether or not there may be some utility in the future. So the take-home messages that I have for today's presentation includes considerations of risk factors of PJP, which I would say the most important one to remember would be the use of steroids, but keeping in mind there are other select immunosuppressive therapies and conditions patients have that result in a overall net state of immunosuppression that does put them at risk for PJP. Those would be individuals who we may consider primary prophylaxis. However, the timing and when to discontinue it still differs between groups and needs to be still kind of looked at in further detail by studies. We are shifting towards PCR now for diagnostics, which hopefully should improve and increase the ability for us to have greater yield and sensitivity towards identifying those with suspicion of PJP infection. It does bring about some other issues, including inability to differentiate between colonization versus true infections, but further studies of this also would be helpful as we move towards this in greater use. In terms of management, to this day, we still don't have very clear evidence to support when to use steroids outside of the HIV population. It may be evaluated on a case-by-case basis, including what I've mentioned before with severe hypoxemia. There may be some considerations, but is not strongly supported by any current evidence available. Resistance still does remain to be quite uncommon at this time, and I would say consider other causes of treatment failure, such as optimal dosing or associated heart failure or ARDS on top for the PJP before thinking about switching therapies or considering resistance as the reason for treatment failure. So that marks the end of my presentation. I'm happy to take any questions at this time, but if anyone has any opportunities to, I would really appreciate for any feedback. This is just a QR code to set. That's an anonymous feedback to complete. If anyone has any time to help out, that'll be great.
Thank you so much, Dr. Lo, and we can leave that slide up to give everybody a moment to catch the QR code. I'll also put in a plug. Everyone who has registered for and is attending rounds will get a link within the next 24 hours to provide feedback through that mechanism as well. And Dr. Lo, we will direct that collated feedback your way once we have it. So thank you for that fantastic presentation, really excellent content. And, this topic being really broad in its reach and impact on a number of patients across a number of different specialties. And I think that's reflected in our audience attendance today. So together with Dr. Chagla, I can, we can field these questions. There is one question in the Q&A, which we can start with. And that is, wonderful presentation. For patients with Cushing's, when would you recommend prophylaxis, I think? And also, at what point would you recommend prophylaxis for patients with on glucocorticoids? So two-parter question there.
Great. Thanks for reading out the question too, and thanks for the opportunity. I guess just to reiterate, I think the question was asking about if a patient's either already on steroids or that they're about to start for management of Cushing's, when to consider primary prophylaxis, if that's correct.
I think maybe the Cushing's is the fact that they have endogenous steroid production. So, like, is there a threshold in that disorder where you would think they'd be at risk in PCP. But yes, then the second part being the prophylaxis for glucocorticoids.
Great. I would have to say, at least from my clinical experiences and with the time that I've gone through different patients who have been diagnosed with PJP, I wouldn't say I've seen too many with development of PJP with just the underlying Cushing's disease as the primary single risk factor. Though I would say that patients that have been, perhaps if they're being further immunosuppressed by other additional therapies that they require for Cushing's, whether or not if they do require some elements of using corticosteroids on top, and if the cumulative dosing of those then ultimately does put them at a greater risk, I may still, even in those cases, consider on a case-by-case basis of considering for the primary prophylaxis here. So I would say it's still kind of a difficult question to kind of address here, because we just don't have enough experiences in these unique separate populations that would be enough to substantiate those recommendations kind of on a bigger scale.
Thanks, Carson. I see Dr. Holbrook's hand is up, so maybe I'll invite her to say her question live.
Thanks. Great rounds and great topic. I wondered if I could just push and get a bit more comment on the risk factors, the medication-related risk factors. We occasionally get asked to opine on potential change of immunosuppressive therapy. So for medicine in the non-HIV population, the non-hematologic malignancy population, there's a number of immunosuppressive medications that you mentioned, Carson, as potential risk factors. But for example, I think TNF-alpha get a bit of a bad rap, a bit of overkill around their immunosuppression potential themselves. When I reviewed a systematic review in that population, the group that had risks of PJP were those who were also on steroids. So my question is, do we know any more about the independent risk of other immune suppressants enough to say, yeah, those themselves really are an independent risk factor for PJP? Steroids, I'd say no doubt, maybe dose threshold a bit in doubt, but other immune suppression medicine, it seems to me the evidence maybe is not quite as good as it should be. Just wondered your comments on that.
Sure, and Dr. Holbrook, and thanks for asking that. When I went through the different articles or papers that tried to talk about these different risks, I find a lot of times the picture is a lot muddier than they are. And as you already rightfully mentioned, patients who are on rituximab perhaps would already have had some bridging therapies, be it prednisone, or depending on their underlying disease, they could also be on Myfortic or other combinations. And I think that's why when I mentioned about the net state of immunosuppression, even then we don't actually have a very clear measure of whom we think would be a group by which certain specific therapies make them directly at risk of PJP. Rather, I think it's the combination of what their underlying disease is, the treatment history that these patients have been on, and what else are they getting in combination together that would put them at risk for considerations of these prophylaxis. But as a standalone or as a single drug, as a associated with increased risk of PJP, I am finding it difficult that there are not many studies like that try to highlight such situations. Perhaps the only one that has a little bit more literature to back them up would perhaps be from the corticosteroids as a standalone, whereas all the other therapies I haven't really come across that to date.
Thanks. I know, as Carson mentioned, the literature is really vague on this, right? And I think that's the issue. There are going to be individual cases associated with immunosuppression, and again, whether that's in that state, whether or not it's their underlying disease, whether or not it's a combination of both, makes it hard to kind of attribute a single drug or a single dose of drug in that sense. Still open for questions. Maybe I'll ask though, Carson, what are your thoughts on duration of therapy or prophylaxis in individuals post solid organ transplant? As I think guidelines recommend somewhere in that 6 to 12 month range, but we have certainly seen data suggesting that transplant patients can acquire late PCP, as well as, as you said, there is even some evidence of transmission of PCP amongst transplant individuals. And so, where do we sit in terms of long-term prophylaxis in those individuals?
Great question, Zane. Actually, this is something that we're still currently looking at. It was based on one of the papers was the one that I quoted just earlier when the SOT group by one of my colleagues, Dr. Haudenosaunee from UHN. What we're trying to look at right now, and I tried to present this earlier last year with one of our initial data, we tried to look at patients who are solid organ transplant and either have received PJP prophylaxis for be it 6 to 12 months or even stopped earlier in select transplant groups. And as you mentioned, what we have found, interestingly, is that, for example, liver transplant patients might be at a increased risk for PJP, which is a bit unusual because compared to the other solid organ transplants, liver transplant actually typically could be as low as on a single drug or 1 to 2 drugs for their immunosuppression in the long run. But what we did find interestingly is that at least in Toronto, the practice of PJP prophylaxis was actually either no prophylaxis at all in this population, even from the get-go, or stopped pretty early post-transplant. And as you said, we are finding late onset PJP, and we're not quite sure whether or not it has to do with the differences in practices of how long PJP prophylaxis is being given in these different select groups, and whether or not there is an appropriate or not duration that we can recommend for these different transplant patients, because they're also unique with different varying combinations of their immunosuppressants for their anti-rejection meds, let alone other complications like CMV co-infections, prolonged lymphopenia that some of these transplant patients can have, and other things that might contribute to their overall risk of developing PJP. And it may just require, rather than kind of a large scale recommendations, select kind of scenarios where you won't follow that usual protocol of the shorter 6 to 12 month PJP prophylaxis here.
Thanks very much for that, Dr. Lo. We've got one other hand up at this point, and I'll just invite Anjali to unmute.
Thanks, Madeline. I was just going to comment on what you were saying, Carson, that the liver transplant population is interesting. And I wonder if it also relates to the point that you were bringing up earlier about low albumin and malnutrition. These patients are cirrhotic, and I wonder if that's a contributing factor for them as opposed to some of our other solid organ type of transplant patients that maybe don't have such issues. And I'm just going to bring up the other point is just going to bring up is just that I think to Anne's point, we don't have great tools to figure out what is someone's immune function when they're on immunosuppression, right? We know they're on these drugs, but we don't know how functional their immune system is. So it would be really useful, I think, if we could, do like Pathogen testing for T cell function or something. I think that would give us a better sense of how much is this person, how immunocompromised is this person? And those are the two things I just want to say.
Thank you very much. I'll invite Dr. Lo if he has any response or reflections on those comments.
I totally agree. I mean, I feel there's a lot of unaccounted risk factors that some of these patients have with specifically in the SOT population. And as Anjali mentioned, perhaps there is concerns with either the albumin level or the malnutrition that some of these patients have, which also have been documented before in risks for developing PJP. And if only we do have, as mentioned, ability to kind of measure these risks, it would be very helpful to kind of be able to properly quantify or stratify whom we think benefits the most from prophylaxis versus those who we may consider shorter courses or being able to discontinue it comfortably. So I think that remains to be addressed.
Thank you so much. And I see there aren't any other questions at the moment. I'll invite Dr. Chagla if he has any additional questions or comments, and then we'll move toward wrapping up.
Yeah, maybe I'll add one more and just to kind of for the pharmacy folks in the crowd. But, there's been a lot of controversy around how we dose Septra for PCP, and knowing that the rate limiting step of the drug is often hyperkalemia and myelosuppression. And so maybe just if there are considerations for higher or lower dose regimens, or, what to do if we are starting to deal with the adverse effects of trimethoprim side of allergy where it can't be given.
So just making sure if there was a question in there for Dr. Lo.
Yeah, I know. Mainly like, are our doses currently adequate, or we should be considering lower doses, or even in certain populations, de-escalating the dose right up the front just to minimize side effect profile, considering again, they often bring in other things that lead to hyperkalemia and myelosuppression.
It's an interesting question. I'm not sure I'll be able to answer this right now directly. I mean, it would be interesting to see, especially for those who we stratify as either mild or less severe PJP. I agree. Maybe there might be some utility in trying to decide whether or not if they could be safely on a lower dose. But I don't think I've come across too much on, maybe I wasn't looking at this specifically during when I was preparing for this presentation, about the optimal dosing or the appropriate dosing, namely because these doses have also been kind of historical, really, rather than anything recent to kind of substantiate that we're actually, in fact, underdosing, overdosing, or not.
Yeah, thanks. I know Todd is in Montreal is trying to do a meta-analysis on this, and I think he's trying to actually recruit for a trial for this. So I think more to come. But yeah, thanks for that. If there's any other questions, I don't see any.
I'm in the chat. There's a late breaking question.
Where's the chat here? Okay, perfect. Thanks for a great presentation, Carson. Thoughts about sticking with the O2 SATs hypoxia as criteria for initiating adjunct corticosteroids in the absence of better guidance?
Thanks, Rami. I agree. I feel, at least based on what I have found so far, though it hasn't made it in any recommendations whatsoever, and even in the larger groups like SOT population, or even among the stem cells, because when I read through the guidelines and how they justified what they're mentioning for treatment, for example, SOT population, they'll say consider steroids, but it's based on, I'm not even sure where they've based where they based that recommendation from, but I would say at least from the systematic review that we could see from the 20-year data, it would be worthwhile to at least use hypoxia as a kind of relatively quick measure to say whether or not someone within a 72-hour period might benefit from a discussion of role of steroids or not. Now, whether or not the dose of steroids and how we're dosing it, and is that the appropriate one that we're using in the HIV population carrying over to the non-HIV population, still remains and begs for more study to support kind of like what are we dosing that would be considered appropriate here.
Fantastic. Thank you very much for that question and for that response. It really sounds like a quite nuanced area that has a lot of opportunity for ongoing research and quality improvement to hone in on some of these unique patient matching the treatment to the patient characteristics. We've got a good link that's been plugged into the chat there for anyone to have a look at. Systematic review, meta-analysis for low-dose Septra for PJP. And another one, Septra dosing for PJP in heme malignancy, specifically a retrospective study. So I'll invite anybody who's participating and interested. Thank you so much to Linda Lee for providing those links. And I think at this point, we will move toward wrapping things up. I'll once again offer tremendous thanks to Dr. Lo for providing this excellent overview on an important topic. And more generally to Dr. Lo for being an excellent colleague and a fantastic physician looking after a number of patients, both inpatient and outpatient across the organization. Thank you to Dr. Zain Chagla, who in his role as head of service for infectious disease, so kindly joined today to help co-host. And thanks to all of you for joining today. Rounds will be back next week at noon. And the topic is, actually, I don't have the topic in front of me. It will be the Hamilton Health Sciences Teaching Medical Residents presenting. That's December 12th. And then the following week, December 19th, will be Dr. Gausia Dar from Clinical Pharmacology and Toxicology presenting. And then thereafter, the last two, the Thursdays thereafter will be canceled for Christmas break, and things will regroup on January 9th. So thanks again to all, and wishing you all an excellent day and a fantastic week ahead. Take care.